neonatal intensive care consultants. We've definitely got some parents. I knew we had some parents here. Some neonatal nurses. We've got some other health professionals. Brilliant. We haven't got Vladimir Putin here. It's always a worry when you give talks on the internet. We don't seem to have any random people on the internet either. That's also encouraging. Alok did say he wasn't going to let in random people, or at least if they didn't put a name, he wasn't going to let them in. Very good. Okay, good. So that was an easy question for you to answer. Let's oh, it's still changing. It's so exciting. I'm going to go to a slightly more challenging question for you. So what I want to do now is to start with this ethical question about who should make major decisions about newborn infants. So let's see if we can. We've got this again. So your options are: who should make major decisions about newborn infants? Important decisions. Parents should decide. Health professionals should decide. Some combination of the two. Health professionals should decide, but parents should agree. It depends. Vladimir should decide. Oh, somebody's voted for Vladimir. Well, I'm glad to see. It depends. So we've got a range of different answers here. We've had 35 answers, lots of votes for health professionals and parents together. A few for parents should decide, but with the help of health professionals. Great, that's really, really helpful. Good, let me see if I can switch back to my presentation. I have, very good. So most of the time in ethics, I say, and you'll be very familiar with the idea that in ethics, well, there's not necessarily a right answer. I'm going to say, in this case, there is a right answer, and none of you got it right. So the answer is, it depends. So why does it depend? So this is the idea of a shared decision-making spectrum. We're all told we have to do shared decision-making in pediatrics, in neonates, but of course, shared decision-making is not one thing. There's a spectrum, and I like this figure. It points to, at one end of the spectrum, you've got 100% patient or surrogate responsibility for decisions. And at the other end of the spectrum, you've got 100% physician responsibility for decisions. And then in between, you've got anything between sort of 1% patient or surrogate involvement to 99%. So I think unless you're right at this end or right at this end, everything else is shared decision making. But there's a huge amount of variation there. You could be equal partners, or you could have parents mostly deciding, but physicians guiding, or the other way around. So where should we be on this spectrum? Well, I think it depends on parents' views, their preferences for decision-making. What support do they want in decision-making? Some parents, and maybe we'll hear more about that in the second half of this session, want to make the decisions themselves. They know what the decision is. They don't want the doctors to be, this is their baby. They feel very strongly that they know what's right for their baby. Other parents say to us, doctor, I want you to tell me what I should do. I want you to make the decision. This is too hard. So it depends on parents' views. It doesn't depend, or shouldn't depend, on which doctor happens to be on. Now, unfortunately, it often does depend on which doctor happens to be on. So I haven't got good data on this in neonates, but some of you might be nodding away and are familiar with this, particularly the neonatal nurses. This is a story from adult intensive care, a study a number of years ago now, where they recorded a whole lot of the conversations between families and the health professional team. And what they found was there was a full range of conversations. Some of them were right down this end. They were sort of driven by the family. Others were right at this end. The doctor was saying, this is what's going to happen. We're unfortunately going to need to move to palliative care. And others were somewhere in between. But what determined this was the physician's preference. It's how they like to run these conversations. And what didn't determine it in any of these cases was the family's preference for how to make these decisions. So it shouldn't depend on this, though it often does in practice. And then I said it depends, it should depend on parents' views, but it should also depend on the situation. So I'm going to step back for a second to talk about the wider ethical picture. So those of you who've heard me talk before will have seen these sort of pictures. I draw them all the time. We have this idea that what we should be doing when we're making decisions for children is we should be acting in the child's best interests. The legal and ethical frameworks that we work on in the UK and in Europe say you should act in the child's best interest. Now that looks very simple. So if it's in the child's best interest to give steroids, come off the ventilator, go to palliative care, then you should do it. If it's not in the child's best interest, you shouldn't. Simple, isn't it? Except if we have this sort of model, then what have parents got to do about it? I mean, what are they supposed to be doing? Why are we even talking with parents? And of course, in practice, we don't think of these decisions in this way. The way that we think about decisions is something like this. There are some decisions where it's clear that it would be in the child's best interest to have a particular treatment. And in that situation, we should provide that treatment, even if parents don't want us to. And so the classic example is a blood transfusion for a severely anemic baby. Parents might have a religious objection, but nevertheless, we should transfuse. Some treatments are not in a child's best interest, and we shouldn't provide it, even if parents are adamant that that's what they want for their child. They're unavailable, they're unaffordable, or simply harmful to the child. They would be, and in that situation, we shouldn't provide it. But a lot of the time, we're in this section in between that's we often refer to as the grey zone in relation to extremely premature infants, but more widely, it's referred to as the zone of parental discretion. It's where, depending on the family, in some cases we'll provide the treatment, in other cases we won't. And this reflects the nature of these decisions, the uncertainty about what would be the right thing to do. And it may be reasonable to either continue or provide the treatment or to discontinue the treatment. Now, one of the things about this diagram is that even within this grey zone, there is a spectrum. There are some where it's more in the, we're more sure that it's in the child's best interest, or we think that it probably isn't in the child's best interest. So we should be directive in our counselling when we are outside or at the edges of the grey zone. So we're going to be more towards this end of the shared decision-making spectrum when we're further away from the middle of the grey zone. So that's the kind of ethical framework. That's why we involve parents in decision-making, because we have this notion of a zone of parental discretion, but how we involve them in decision-making should it depend on their wishes and values, but also on the nature of the decision. A decision about postnatal steroids is very different from a decision about a blood transfusion. It's very different from a decision about antibiotics for a septic infant. So we have to think about these decisions differently. I'm going to move in a different tack now. I'm going to move in a very practical tack and say, because lots of the people on this session are clinicians, so this is going to be a very familiar scenario. Mary is a mother who's presented in preterm labour at 23 weeks and 6 days. Labour is thought to be likely to proceed. You've been asked to counsel, in inverted commas, her. Now, how are we going to approach this? Again, in a more interactive session, I'd get you guys to give me some ideas, but I'm just going to tell you some of the things that I normally encourage that I think we have to think about. And of course, one of the things that people will do first is they'll say, okay, well, I need to make sure I know what the facts are for an infant born at 23 plus 6 weeks. So we go away and have a look in the textbook, or maybe we'd have a look at this sort of flow chart, this sort of infographic, which came from the new BAPM framework in the UK a couple of years ago, talking about the average outcome for infants born at a particular week of gestation. So we might go away and try and remind ourselves of the facts in case we can't remember what they are. Of course, if you've heard me talk before about extreme prematurity, or if you've read the BAPM framework, or if you've read much around this, simply getting the average figures for 23-week infants is not enough. You've got to know all the relevant facts. So here are two different infants at exactly the same gestation. One is growth restricted male, has had prolonged rupture of membranes, is going to be born in a level 2 center, has had no steroids. The other has a whole set of more positive, favorable risk factors. You simply rely on the average figures for 23 weekers, you're going to be A, providing very misleading and incorrect figures, and B, potentially be misleading parents as to the chances for their baby, and therefore maybe making the wrong decision for this baby in this family. So you have to have the relevant facts, the facts that are relevant for an individual situation. Third, you need to work out, before you embark on the discussion, what sort of discussion this is. So we talked already about different types of decisions. So are you up here in the interest diagram or down here? In terms of these decisions about embarking on treatment for an extremely premature infant, is this a situation where resuscitation is mandatory? That sort of example is an average 25, 26 weeker. We're not going to be embarking on a should we, shouldn't we conversation with parents. Is it a situation where resuscitation is not an option because actually the infant's prognosis is thought to be so poor, 20 weeks gestation, 21 weeks gestation, for example? Or is it one where we're in the gray zone, we're in the zone of parental discretion, in the BAPM framework, rather than these different colors, we used the sort of colors of a traffic light. Are we in an extremely high risk situation for the infant, a moderate risk, or a high risk category? So we need to have a sense of what sort of conversation are we in. Are we engaging with parents? Do we need to make a critical decision, or do we have a decision already, and what we need to be doing is supporting the parents with what's the right thing for the baby? Step 4, you remind yourself that the parent is not a Vulcan. So if you've ever read Annie Janvier, if you've ever heard Annie Janvier talk about antenatal counseling, you know what I'm talking about already. So Annie Janvier is a Canadian neonatologist who herself had an extremely premature infant, and who's very passionate and articulate about how the way that most professionals approach these decisions assumes that the way that what parents need is all these statistics, all these numbers of all these different, so there's a 20% chance of this, and there's a 30% chance of that, and a 15% chance of this level of disability, and if that happens, there's a 15%. But parents aren't Vulcans, or at least most of them aren't. And so that's not going to be a helpful way of approaching these decisions. So although having the facts right is important, those facts may not be helpful to communicate, at least not in the way that the ultra-rational, logical Dr. Spock would approach these decisions. Okay, step 5. So we haven't even got in the room yet. This is all the stuff that we do before we go in the room. Bring some written information if you can. There's very little evidence around prenatal counseling, but here's one of the bits of evidence that there is. If you provide written information, parents have a better recall of statistics about long-term outcome. Whether or not recall of statistics about long-term outcome is what really matters is another question. But I think there's good reason to think that written information is helpful. And as many of you know, there's a template in that the BAPM framework includes. You can give parents that infographic, and we have some written information in Oxford. And there's some evidence from the wider intensive care setting that providing a written information to families in adult intensive care potentially reduces anxiety, depression, and post-traumatic stress for families of dying patients, reduces the incidence of poor understanding for families of adult intensive care patients. Okay, so that was all the preamble. Now we've actually got to do the communication bit. And I think one of the things that I have learned over time from our palliative care and oncology colleagues are about some very simple tools that we can use for communication. And it applies to antenatal counseling and to other decision-making settings. So one of the tools that they talk about is the notion of ask, tell, ask. Or as I often think, ask, 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 tell, ask. So when we go into these conversations, we often go in, we've got all this information in our head and we're bursting to kind of vomit out all this data and information. But actually, what we need to do first is get some information from the family. We've got information from the medical records and the obstetricians, and they've told us some of the relevant statistics, but we need to know some other things. And the questions that we ask are not necessarily the medical questions. And these questions are versions of the ones that you may have heard Atul Gawande, the great American surgeon and writer, talk about in his book, Being Mortal, their version of his 4 questions. So we might start with, is now okay to talk? Is there anyone else you'd like to be here with you? And then moving on from that, if we are going to have a conversation, is to start with, well, what's your understanding of what's going on? What have you been told? What have you read? So understanding where what the parents' prior understanding is really important for these conversations. Has anyone do you know anybody who's had a very premature baby? Secondly, big question, what's most important for you? What are your hopes in this situation? Of course, it's not in the context of extremely preterm birth. It's very simple and straightforward and obvious what parents' hopes are going to be. 99.9% of the time, they're going to be hoping that their baby's going to survive and be absolutely fine. So sometimes it's important to ask, what else are you hoping for? Particularly where things are looking very troubling. The flip side of hopes is to ask about fears. So I'll often frame it that way and to say, well, here's a more tricky question. What's worrying you the most? What are you most scared about? What are you most afraid of? Gawande talks about what outcomes are unacceptable to you. What are you willing to sacrifice and not? And I think sometimes these sorts of questions can be helpful. I confess I don't often phrase it in this sort of way. And I've got a 5th question here that I often ask, which is whether the parents have a name for their baby yet. Remember, I haven't told them anything yet. This is all the ask, 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 ask. Once you've done those questions, then you can sell something. And I think in this setting, what you want to do is to give parents the big picture. So really understanding the overall situation. Your baby's going to be born extremely prematurely. However, most babies at this gestation will survive, and if they're provided with intensive care, or sadly, a large number of babies who are born this early don't survive, even if we attempt intensive care. We need to provide the big picture. We need to make sure we're clear about what their choices and options are. And we need to give them specific information relevant for their situation and their baby based on what they've just told you is most important for them and they're most afraid of. So this is a sort of way of capturing the big picture. This is a diagram that we've used in our parent information. It's a little bit similar to the BAPM infographic, but it's a way of trying to capture, because most parents don't instinctively, in fact, most of us don't instinctively understand statistics intuitively. So here's a way of capturing the overall outcome for babies born around 23 to 24 weeks. If 10 babies are born at 23 or 24 weeks, it's likely that 5 of them will die, even if they have intensive treatment. 1 baby will survive, but with very serious lifelong disability, and 4 babies will survive without a serious disability. So that's a way of trying to capture the big picture. When we talk about options, I think it's very helpful to talk about what some families choose. So to say some families find that in this situation, they are very clear that they want us to embark upon intensive care. Other families are clear that that's not the right thing for their baby. They think their baby's born too early and their chances are too low. And the right thing to do would be to hold their baby and focus on baby's comfort rather than invasive intensive care. And presenting it that way allows parents to look and say, which of these fits with me? Which do I resonate with? And we can ask them that. Do either of these sit right for you? How are your feelings in comparison to these choices? Then we're going to ask some more questions, and at this point, before giving more facts, we need to say, ask them what their thoughts are, what they're thinking about, what their views are, reflecting that this is a lot to take in and must be difficult to hear. I've got a few do's and don'ts. So please don't give the family a shopping list of options or alternatives. Please don't ask them if they want us to do everything, or even ask them if they want us to resuscitate the baby. I don't think those questions are helpful ways of helping parents with a complex decision. We do need to understand what their wishes are in relation to embarking on intensive care for their baby. But asking, do you want us to do everything, is only ever going to get a single answer. Of course, we want you to do everything. But what does everything mean? And don't tell them that you'll make a decision in the delivery room based on how the baby looks, because I think personally that's a failure of counselling and decision making, because we can't make an informed decision in the delivery room, with the exception that some babies are born in exceptionally poor condition, and that might mean that it's then appropriate to embark on palliative care. And please do break the information into chunks, give relevant facts, tailor the discussion to the family and their priorities. That's why you have to do all those asking questions first, check for understanding, and sum up key points at the end. I'm not going to talk about disagreement because I've gone on a bit already. We might talk some more in questions now or at the end, but I want to make way for much more important people to talk and the input that I know you're all keen to hear. So I'm going to stop there. Thank you very much.